Hello everybody, my name is Jennifer Porter. I would like to introduce you to my DNP project, which is the reintroduction of the PHQ-9 policy to improve administration rates. So, my name is Jennifer Porter. My DNP chair, sorry about that, was Dr. Snell, and then I actually had a lot of people helping me with my project, which I'm very grateful for. The committee member, my main point of contact was Heather Berger, and actually the quality initiative team at Stanford was helping me conduct my project as well, because they were also equally wanting this project to be successful. So for the phenomenon of interest, major depressive disorder, MDD as many of us call it, is one of the most common mental health disorders, which affects more than 17.3 million adults in the United States. Some research suggests that major depressive disorder is not properly evaluated or diagnosed within the healthcare systems in the United States. And I just wanted to back up a little bit at this 17.3 million adults. The study that I got that from really pointed out strongly that number is very low compared to what likely is just due to underreporting of the diagnoses. So tools such as the PHQ-9 can assist to detect and evaluate the severity of symptoms related to the major depressive disorder. So that's one thing that I really liked about the PHQ-9, is that it's not only used to detect major depressive disorder, but it's also used to help evaluate how bad it is. So symptoms of major depressive disorder can impact an individual's ability to function in daily life, and we're going to learn more about that later on. Research supports that suicide is often the result of unmanaged symptoms of major depressive disorder. Sadly, someone completes suicide every 11 minutes in the United States. So purpose and aims of this project. So my project was a quality improvement project, which aimed at improving adherence to the PHQ-9 administration protocol. I wanted to educate staff, support staff, which included 6 nurses that work for the medication providers, on the PHQ-9. I wanted them to understand how to administer it, why we want to administer it, what its importance was, and what the benefits are for the patients. I also wanted to improve detection and management of major depressive disorder in the patient population of rural community where my project takes place. So for every DNP project or every research project, you always have to have your PICO question. So my PICO question reads as follows. In patients who are experiencing a mental health disorder, ages 12 and up, does an educational intervention for direct support nursing staff regarding the consistent use of the PHQ-9 as compared to no educational intervention improve detection of depression and adherence to completion of the PHQ-9 post as compared to pre-intervention rates over an 8-week period? So, what is major depressive disorder? So major depressive disorder is a disease, unfortunately, that is very prevalent in the United States. Symptoms of the disease include feelings of sadness, hopelessness, loss of interest or pleasure, sleep disturbances, fatigue, appetite changes, concentration deficits, and impaired thinking. Research suggests that many Americans do not seek treatment for these symptoms once you begin to experience these symptoms. And it's important to notice that many of these symptoms can be attributed to other medical conditions. So that's why it's really important to make sure we have a clinician involved to make sure that when we do diagnose major depressive disorder, that we really don't have something else underlying. So the consequences of untreated major depressive disorder. The National Institute of Mental Health estimates that 17.3 million adults will suffer from depression during their lifetime. That is 7% of the American population. That is a bit alarming. So that's just under 1 out of 10 Americans, if you really want to take a look at it. So Patients who have one mental health disorder are at risk for developing another. So when I think about this, I think about when I am seeing patients during the day. Oftentimes, I'm not seeing patients for one disorder, I'm seeing them for multiple disorders. So that's something to keep in mind. On average, about $210.5 billion is lost annually due to deficits in the treatment of major depressive disorder. Things that we include in this assessment include missed time from work, reduced productivity from work and home, and the cost of medical care. One thing that I wanted to point out here is that unfortunately with the mental health system, we're more reactive than proactive. So one thing that my project was very pushing for, or was very so much pushing for, was that we be more proactive with things. We're detecting major depressive disorder early as opposed to catching it late. So, patients with untreated depression are at higher risk for developing cardiac disease, lung disease, cancer, and diabetes. In addition to the decrease in physical health, early detection and treatment of depressive symptoms can improve the quality of life in the patient. So while we do know some pathways, it's important to know that there's still a lot of research out there that hasn't been done that figures out how mental health is connected to physical health. We very so much know that it is, but there's still a lot unknown about how it is. So that's one thing that we're still working on. That's just one thing I really wanted to point out here. So what is the PHQ-9? So actually the PHQ-9 was done in response to a report that came out basically saying that we were really lagging on our mental health treatment in America. So we got this grant, some of the top mental health professionals in the state got together to figure out what can we do to make this better. So it was developed by Dr. Pfizer, which I actually was really surprised that he's an actual doctor. I took the Pfizer shot, and I've heard of Pfizer other products, but I realize now who they're named after. Janet William and Kurt Kroenke, utilizing the Pfizer grant. The PHQ-9 consists of 9 questions that can be self-administered to the patient. These questions come straight from the DSM-5. So it's not questions that are scientifically backed. And it is recommended that if a patient scores high, which is a 5 or higher on the scale, that they be referred to a mental health professional to be formally evaluated, if need be, treated for major depressive disorder. However, it's imperative that an individual be formally evaluated, as the positive PHQ-9 screen does not always indicate an appropriate diagnosis for major depressive disorder. This is one thing I really want to highlight here. Just because somebody scores high on a PHQ-9 does not mean they have depression. I have a lady right now that I am seeing that she scores high every time, but she is about 8 months pregnant. And she looks at me and she says, that ain't going down until I deliver this baby. So you want to make sure that you're evaluating why. Why is somebody having low energy? Why are their concentration levels low? If they're very sick and they've got a lot of medical things going on, if they're pregnant, if they're getting chemo, a lot of that could be affecting things. So we want to make sure that it's not from a medical issue. So the 9 questions, and you rate it on a scale 1, 2, 3, 4. So they rated, and there is no wrong answer. So first one's little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling or staying asleep, or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, or that you are a failure, or that you've let yourself down, or let yourself or your family down, trouble concentrating on things such as reading the newspaper or watching television. I find that funny because you can tell it's been done a while ago. Nobody reads the newspaper anymore. Moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety and restless that you are moving around more than normal. And the last one, thoughts that you'd be better off dead or hurting yourself in some way. So you have the patient fill this out, and then you add up all the points, and then you score it. And then you also want them to fill out this last question. Just if you've experienced any of the problems, how difficult has this made it for you to do your daily life? Answers are not at all, somewhat difficult, very difficult, and extremely difficult. So challenges to administering the PHQ-9. First one, lack of staff and time constraints within the healthcare system. This one is no surprise to me, and it should not be a surprise really to anybody who is watching this. There is a severe need for manpower within the healthcare system. You know, my specialty is nursing, so I feel it most in nursing, but the lack of staff, the lack of workforce has led to a decrease in the quality of care that the patient receives, and the workload of the healthcare providers then increase, which that negatively will impact the patients. One thing that actually really surprised me was the attitude of the providers towards the tool when it comes to administration. I originally didn't think this would matter in my project, but I'll get to why it mattered in my project a little bit later. But due to lack of confidence in the tool, providers may not feel that it's a priority to administer the tool. Many providers didn't like it for a variety of reasons. They felt they were losing their autonomy. They felt like it wasn't valid. I had one provider tell me that they're asking the exact same questions during their interview, so this is just a double take, many things. And then also the stigma when it comes to mental health care. That one's been a challenge for us who are providing mental health care for quite some time now. So benefits of the PHQ-9. The PHQ-9 was a favored tool of choice for providers when it comes to screening for depression-related symptoms. In fact, the American Physician Association backs the PHQ-9 as the standard of care when it comes to self-administered surveys for depression. It's important to note that there are many surveys out there that you can give for depression. Beck was the one right behind PHQ-9, but the PHQ-9 really is the one that is the gold standard. In fact, they recommend that it be given at every primary care visit. PHQ-9 serves as a tool that it can assist in the middle of a provider shortage, as it can be administered by support staff as a pre-screening for depression symptoms. So it's really nice that you don't need a provider right away until they actually score, and then you need to refer to the provider. So what did I do? What is my project in a nutshell? So first I went through the planning phase. I met with my DNP chair. I met with my facility or my committee chair. I really wanted a project that was straightforward, to the point, and easy to conduct. So I did a needs assessment first. I sat down with the facility and the quality improvement team, and I said, what in your facility is lacking? Where can I help you? And then they said that, you know, our numbers, our PHQ administration, they're low. They wanted them to be above 78%. And they were getting consistent like 30s, 40s across the board. And so that was really an issue. So we came up with this project. So then I collaborated with my committee chair, the clinical director, quality initiative staff, and the DNP chair, and we started formulating this project. And then all that took place prior to November of 2023. Now, many of you know we had to go through the IRB board for Maryville and get their approval. I already had the facility approval because they were totally on board with this project. They are, like I said, short on staff. We all know that, so they were happy to have a student come in and help with it. So in November of 2023, I got IRB approval from Maryville University. So in November of 2023, I gave an educational presentation to the support staff, which was 6 nurses that work for medication providers at a behavioral health clinic, outpatient clinic, on the PHQ-9, its importance, why we administer it, its benefits, all that. They were able to administer one to me to show that they were sufficient in it, and they also took a self-administered survey as well to show that they understood the knowledge. And from that point, from November to February, we did an 8-week data collection period where basically every Friday I went into their electronic health record. I did not need any patient identifiers to do this. I was able to just grab a number at how often are we administering the PHQ-9. So after February, I did take some time off school because I decided to go to Europe. Fun. And then in August, from August to December, I did my last semester. And I did my EMR review and my data analysis, which I'm finishing up now. And kind of figured out why I got the results I got, and whatnot. So for my results, I really did the upper tail Z test, although my results kind of speak for themselves when you look at them. I probably didn't even need to do a whole lot of calculations, but I did them anyways because we're supposed to. So the null hypothesis was 0.78, the level of significance 0.05, number of items of interest 1,889, the total sample size 3,617, standard error 0.0069. So it was a bit disappointing for me. We did not reject the null hypothesis. There was not sufficient evidence to suggest a decrease in the ratio in the pre and post test intervention. So we did not get those results up to that 78% where we really wanted them. But we'll talk about that. We learned from it. So still good came from this project. So actually, I like this graph a lot better. It's easier to understand. So the red indicates where we were non-compliant with administering the PHQ-9. The green indicates where we were compliant with it. We were compliant with 1,889 patients. We were non-compliant with 1,728 patients, so almost right down half of it. So we had a little bit of improvement, but not where we want to be. So limitations and things that we can learn from this. So when I conducted my project, the COVID-19 pandemic really came into play. And I know probably every single project has this listed as a limitation. So actually, the pandemic was just about over, and our clinic had gotten pushed into telehealth very rapidly. We had not done any telehealth visits until the pandemic hit, and then boom, everybody was telehealth. So we are still trying to figure out how do we best go about it and what is best practice. So when I did my project, I planned to educate the nurses. So what I didn't plan for was for patients to not see the nurses or not have to go through the rooming process and to only see the provider, which, if you remember, I talked about providers not being totally bought into the idea of the PHQ-9. This is where it came into play. I wish I would have included providers in the project as well. I was really trying to do like more of a nurse-driven protocol here as opposed to a provider protocol, and this is kind of where it got screwed up. So there's still so much we have to learn about telehealth. What is best practice? How do we incorporate things into it? And I'm sure we've all heard this many times. So that was the biggest thing that we really need to learn as a facility is how are we going to make sure that we fit everything in? How are we going about this? Whose responsibility is it when it falls into a provider's lap who doesn't believe in it, but it is still our policy? So, and then the last one, the nursing shortage. Nursing's often understaffed, and due to the heavy workload, they struggle to administer the PHQ-9. If they did, they at times forgot to enter the data into the workflow. There was one specific time where I even remember a nurse actually came running to me and she was like, hey, I forgot to enter this, but here it is. So that was a big thing for us too. So we've been battling this as nurses, I think, for years. And I think one thing too is keeping nurses at the bedside. A lot of nurses are moving on. So this is something that I think we really do need to get creative as a profession in general. For nurses, how do we get more? So again, I want to thank you guys all for listening to my project and listening to me ramble on. I included lots of references, so you can take a look through them. But I am welcoming anybody's feedback. I really appreciate all of you for taking the time to listen here, and I enjoyed doing my project. I wish you guys all the best in your future endeavors, and I hope you guys enjoy your holidays.